A warmest greeting to all. Thank you for making time and joining us in this live best practice in thalassemia treatment during COVID-19 pandemic. For your information, this event is only for healthcare professionals and will be recorded. Although all attendees are muted throughout the meeting, we encourage your participation in this webinar by submitting your questions, if any. We will compile these questions for discussion during our Q&A session later and try our very best to address them. If I may have your attention to the presentation slide now, please allow me to quickly guide you on how to raise questions. For those of you who are joining this webinar via personal computers, you will see a similar screen as shown. The first button, which resembles a microphone, should be muted and turned off at all times. Next, we have the meeting chat box, which you may use to send in your questions. For those of you who are joining this webinar via mobile devices, be it mobile phones or tablets, you will see a similar screen as shown. On the top right of your screen, there is a meeting chat box which you may use to send in your questions, whereas the button below it is the microphone which should be muted and turned off at all times throughout the webinar. I shall now pass the virtual stage on to Cozy of Novartis.
Good morning and good day to everyone. Thank you for taking your time today to attend this Novartis Thalassemia event in collaboration with the Malaysian Society of Pediatric Hematology and Oncology. I understand we also have our fellow physicians from Singapore, Taiwan, Vietnam, and Brunei participating in this event as well. So we are very, very happy today. Without further ado, I would like to invite our chairperson for today's event, Dr. Zulaiha Muda, Senior Consultant Pediatric Hemato-Oncologist from Hospital Tunku Aziza, or previously known as Kuala Lumpur Women's and Children's Hospital. Over to you, Dr. Zul.
Okay. Thank you, Cozy. Instructions. Hello and welcome everybody. Thank you for tuning in with as mentioned by this webinar is for this and Hematology Oncology, in short, MASPO. And this webinar we focus on looking at the best practice treatment in 19 pandemic. I'm Zulaiha Modi, coordinator for as you see in on our agenda, we have two speakers here. They are Prof. Vip from Thailand, as well as Paylin from Penang, up north, Malaysia. As you know, this is live webinar, so you will be able to post questions, and we will try to accommodate and address during Q&A session. So we shall go with our program now. It's my pleasure to introduce to you our first speaker, Prof. Viprakrasik. We actually don't need any further introductions. As you can see from his
Dr. Zul, you are muted. We cannot hear you.
Okay. Okay, so it is my pleasure to introduce to you Prof. Viprakrasik, who is a professor of pediatric at Department of Pediatric Thalassemia Center at Siriraj Hospital, Mahidol University, Bangkok, Thailand. His major research focus has been on translational medicine to bridging between molecular biology to routine clinical practice in hematology. Using the most common inherited disease in Asian population, that is thalassemia, as his model, he has extensively studied these conditions in several aspects, including basis, pathophysiology, genotype, phenotype correlations, molecular diagnosis from routine services to pre-implantations, genetic analysis to non-prenatal tests, newborn screening. So he received his best research award of the year in 2016 from National Research Council of Thailand and the Sultan of Khalifa Award from UAE for the research for Excellence Center for Thalassemia Care under his supervision in 2014. Prof. Vip also has authored and co-authored more than 150 peer-reviewed publications, and he has written many reviews in thalassemia and iron-related complications, as well as chapter in major hematology review for American Society Hematology and ASH Hematology. So as you can see, this probably have extensive CV. So we are fortunate to have him here with us to share his topic today, best in thalassemia treatment during COVID-19 pandemic. Prof. Vip, we shall invite you to deliver your speech. Thank you.
Thank you very much indeed, Dr. Muda. It is my great pleasure to be with you all here this morning. Can you hear me properly from Thailand, Bangkok?
We all can hear you.
Okay, perfect. Yes. So shall I start with my presentation?
Yeah.
Okay. First of all, I would like to thank Malaysian Society of Pediatric Hematology and Oncology for such a kind invitation for me to do this very special lecture in this very special era. And I think, it's probably something that once in a lifetime that you will never encounter it again, and hopefully not, okay? And also I would like to thank Novartis and also especially Kosi for his patience, his diligence in order to get this event to become available. I've been asked to talk to you guys today. Can you hear me properly? Is there any problem related to my acoustic and the quality of my sound?
Yes, we can. Please proceed.
No problem, right? Okay. All right. So shall I continue? So I've been asked to do some very special lecture, which I haven't done it before. Okay, and related to the topic of the best practice in thalassemia treatment during the COVID-19 pandemic. So it's a very important task and very special because we are in one of the most important history of the mankind. So I'm just thinking that looking back for what's happening to us now in 10, 20 years to come, we are in the middle of a very important history of mankind. And it's also very important for us as hematologists who are taking care of patients with thalassemia that this special virus spreading throughout the world, including our Southeast Asian region, Thailand, Malaysia. We also have been affected by this infection. And how can we deal with that personally and also helping our patients, especially patients with thalassemia, that we all know that they are immunocompromised. We all know that these patients, they are more susceptible to infection. How can we make the best for them? So today, I'm going to review you about the current status of the COVID-19 in the world, in Thailand, and of course in Malaysia, and discuss regarding the impact of the COVID-19 infection in hemoglobinopathies, and also sharing the potential challenges in treating patients with thalassemia during this difficult time. I think I can say we are in the middle of the war, and this is the world war with the virus. And we are not against each other as the previous two world wars that we have, but we are fighting all together to manage and to survive to our enemy, which is this SARS-CoV-2 virus. And we also have to help protecting our patients who are a vulnerable group. So we know that our patient has associated comorbidities. Some of them, or most of them, in some country, has been splenectomized. And of course, they have the iron overload complication. And all of these morbidities, all of these underlying issues that our patients have will make them even more vulnerable to the COVID-19. The issue regarding the blood transfusion also very, very critical during this time because we have lockdown in several countries and some of the patients afraid of getting infection through the blood transfusion. So today we're going to review the evidence whether will we increase their risk to catch the COVID-19 through transfusion or not, and discuss related to the chelation therapy and the other treatment that our patient has during this COVID-19. Should we modify? What should we do related to the transplantation, gene therapies, and all the new bone marrow improving agents such as ispatasine. And finally, this is the request from the organizer that suggesting some management during this outbreak of the COVID-19. So I would like to start with the first fact about the COVID-19, which is, I think all of you know very well related to the COVID-19. Just a very quick summary. So the coronavirus disease 2019 or the COVID-19 is an infectious disease caused by the severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2. So the COVID-19 is the disease itself, but the virus is the SARS-CoV-2. So it was first identified in December 2019 in Wuhan, China, and it has resulted in an ongoing pandemic. And actually, Thailand was the second country that has identified the SARS-CoV-2 infection in our local people. And there is no wonder because Thailand was one of the major tourist hubs for the Chinese people. And this is the data from the most updated, the 4th September, which is just yesterday, that at present we have more than 26.3 million cases have been reported across 188 countries and territories, and resulting in more than, I'm afraid this is very horrible, 869,000 dead around the world. And this is a very, very critical condition indeed. The SARS-CoV-2 virus has a composition as I show you on this slide. So this is the RNA virus and it's composed of the membrane protein and also the spike protein, which is very important for the viral invasion. And on the cell surface also contain the hemagglutinin esterase dimer and also the envelope protein, which is enclave the nucleocapsid protein and the RNA inside. This composition is very important because we know that for the pathophysiology of the COVID virus, it can bind to the ACE2 cell surface receptor on the epithelial cells, especially in the nasopharynx and also the upper respiratory tract, in order to get inside by fusing the S or spike protein to the ACE2 receptor and causing the host cell invasion, and that leads to several pathophysiology of the disease itself. The composition of the virus is kind of similar to several other coronaviruses that we have identified before. So there are a few mutations that make them different and have not been recognized by our immune system. Moreover, knowing this genome of the virus very important because we use the detection of these viral genomic DNA as the standard for the diagnosis of the COVID-19 infection. And at present, we use the reverse transcriptase PCR or RT-PCR because this is the RNA virus, detecting several genomic regions of the virus to make the diagnosis, such as the S or spike genes, the N or neuraminidase, and the ORF region, which is not shown on this slide. So the infection of the COVID-19 are taking around, up to 5 days of the incubation since the virus has been attached to the ACE2 receptor. And after that, we can detect the virus using the RT-PCR after we have taken the sample through the nasopharyngeal swab. And during the first 8 to 10 days, that's the period of the viral shedding, that can spread the virus to the other people. Some of the people will develop the clinical symptom and the ongoing the antibody response as well. However, the most important clinical presentation of the COVID-19 infection is that up to 30% of the infected cases are asymptomatic. So they don't presenting even, with cough or upper respiratory tract infection or even fever. So this asymptomatic patient is a very problematic because they can spread the virus to the other people. And of course, people with the risk, such as the aging, male, the history of the cigarette smoking, and some other, pre-existing underlying conditions such as the hypertension, diabetes. This make these people are more at risk to get a more severe disease, moderate to severe disease, and some of them develop a rapid respiratory failure, and some of them have even the most critical systematic involvement that we know as the cytokine storm. So that's why the mortality of the SARS-CoV-2 infection is much higher compared to the other coronavirus infection. How about the situation of the COVID-19 in Thailand? So I just took this picture from the WHO website, and this is just to show you the data several months ago in March 2020, that when we have the height of the viral spreading throughout our country. So you can see that we have only few provinces that have not been affected by the virus. So these provinces show with the white color. So some provinces are has a very high number of the patient or people who have been infected, especially Bangkok, as you can see on this slide, which has a very brown color. The area which has been clouded with tourists, especially from China, such as Chiang Mai, Chiang Rai in the north of Thailand, Phuket, also has been covered with a very high number of the infected individuals as well. And as I mentioned earlier, Thailand was the second country in the world to have been affected by the SARS-CoV-2 virus. And this is the number of the virus as the 3rd September, which is just a few days ago. In total, we have 3,400 infected cases and 3,277 recovered already. Less than 100 is receiving the medical treatment, and we have around 58 deaths, which is one of the lowest rate of the SARS-CoV-2 infection in the world. And at present, we have around 1 or 2 new cases per day, and most of them are cases which we have imported them back from outside Thailand. Actually, at the end of last year, there was a very interesting report that have been published, and I think some of you may know already that Thailand has been described as one of the most prepared country to respond to a pandemic or epidemic. And this is the evaluation, I think, is from Johns Hopkins Group. And we ranked as the number 6 in the World Health Security. Actually, the number 1 is United States, and followed by the United Kingdom. Actually, this pandemic of the COVID-19 is very important because it's the real test in the real life to show that we really have well prepared for the pandemic or not. And I think based on these statistics, we probably have shown to the globe, to the world, that we are doing just all right, and maybe even better than the number one or number two on the list. And also more recently, there's a global COVID-19 information website that they have updating this the information about how we recover from this pandemic of the SARS-CoV-2 infection. Actually, the Australian was number one and followed by Thailand. And this is the data in June this year, of course. And if you are interested, you can just go to their website of the global COVID-19 index. And through this website, and this is the data that I took from yesterday, just for my fun to see, because this is the real-time index that they calculating based on several parameters, number of the new cases, how we deal with the infection, the number of the testing or screening active case surveillance that we can do. And well, I'm very happy to show you this. This is the most updated. Now we still rank at the number 3, but followed by Malaysia, my second home country, to have, ranking followed by Thailand. And only 3 countries from Asia, and the other country is Taiwan, is ranked in the number 6. So we have a very good recovery index, both Thailand and Malaysia. In terms of the new cases, we just celebrating 101 days without the new local infection patient. However, the following day, which is on the 3rd of September, we had discovered the first case of the local infection. And we're still investigating whether this first case will become a super spreader and leading to another widespread of the COVID infection or not. But hopefully, based on our experience that we have, we shall be able to contain the spreading of the infection itself. And also, we don't need to do a whole country lockdown, as we have done from the early April of this year until May. Because the infection of the coronavirus, of the COVID-19, is a very new condition to all of us, and we have not been prepared. It's like we have been all hit all together with a big hammer for every country. So I still remember that early this year, when I started to hear about this infection in China, I thought it's probably like, after a flu infection or, the bird flu or even like MERS infection that seem to be, are locally spreading and not become a global issue. I went to UK for a meeting in February this year, but soon after that, as you all know, that the magnitude of the problem seemed to become a global pandemic, and as you all know, we are in one of the most important history of mankind. When we first started in Thailand, we have several limitations related to the infection and how to contain the spreading of the infection. Me, myself, as a hematologist, asked how can I help my country to deal with this issue. You may think that you are a hematologist and you're treating red cell disorder. How can you take part in terms of the helping the country? I've been asked this question before. I'm very fortunate because, on the other life, I'm a molecular biologist and I'm working with the I'm working with the human DNA analysis for over 20 years. The viral DNA and the infectious molecular infectious detection has not been, my cup of tea before. However, we are in the war, so whatever we can do, we shall be able to help the country. So one of the most important pain points of the COVID-19 pandemic is the sample collection. As you know that the disease itself, the virus itself, is very contagious. So if you want to collect and make the correct diagnosis, you have to do nasopharyngeal swab. And to protect our healthcare practitioner, medical doctor, clinical scientists, nurses, or medical technologists, we have to wear this PPE, which is a very horrible, especially if you remember we start to have this spreading in April and May, which is the most hottest month of the year, is the bloody summer in Bangkok, in Thailand. So it's a very, very difficult to do a mass screening for our country. In Korea, they have developed these mobile cabinet for the sample collection that the healthcare practitioner can work inside and put through the iris globe port to collect the sample from the people inside. So I just helping to design and develop the first prototype of the biosafety mobile unit for the COVID-19 by a Thai hematologist, which is myself. And after the use of the testing, I donated the first prototype to our His Majesty the King, which I show on this slide. So in this unit, I designed the unit to become a positive pressure unit. So people who work inside will not get the virus from the suspected individual who came for the sample collection, because the virus will not go inside this positive pressure. And we also have a measure of the use of the disinfectant to clean the whole area around this mobile unit. And this mobile unit had been designed on the back of a simple truck. So at present, His Majesty the King has a commission for us to produce over 13 units. Then we use it around the country. More recently, as I mentioned earlier, we have a new local infection. So the mobile unit just went to the hotel and to the condominium that they stay, and we collect over 1,000 samples per mobile unit in a day. So at present, this mobile unit has been very active on the case surveillance around Thailand, and we have used it for over 100,000 sample collection for the COVID-19 RT-PCR since May 2020. The other important pain point is at the inadequate lab facilities. As I mentioned earlier, that the SARS-CoV-2 infection is very highly contagious, it's airborne, and it can be very lethal. So at the beginning of the COVID-19 pandemic in Thailand, not many laboratories in our country can deal with this respiratory virus detection. I think it's less than 5 laboratories in the country that deal with the respiratory viral infection before, because in order to make the diagnosis and also safe for the clinical scientists, they have to work in a very well-controlled environment. In other words, the biological safety laboratory, and this has been standardized into the different level. So I also developed the BSL2 Plus, the biosafety laboratory level 2, and probably one of the first, the private, this kind of laboratory since March. And we start to provide the service in April. And since the beginning of our laboratory, several laboratories around the country has been foraged. And of course, it has to be standardized and certified by our Ministry of Public Health. We have over 30,000 testing have been performed in my laboratory. So this is just the picture of my design on the negative pressure room, which is we have a double negative because in the room itself it's around minus 15 Pascal negative pressure, and inside the cabinet that we work to handle all the viruses, also additional a negative pressure control as well. And in order to make it safest for my healthcare practice, my clinical scientists, to do all the testing with the most safe condition. So at present, in Thailand, we have over 224 COVID-19 laboratories that we can have a total capacity to test over 100,000 samples per day. So I'm sorry that this slide is in Thai, but I just took it from our Ministry of Public Health website yesterday to show that in Bangkok alone, we have 83 laboratories, and outside our capital, we have 141 laboratories. Majority of the laboratory are from the government sector, especially in the outside Bangkok. But we also have around over 70 the private sector laboratory in the private hospital and the private laboratory that provide services and for the RT-PCR for the COVID-19 detection. And finally, also very important, when we start with the COVID-19, we don't know much about the virus itself, and it's caused a very, big fear throughout our country because we don't have the adequate knowledge. So in order to help that, I become a Mr. COVID-19. I have my own fan page that communicating with our country and followed by over 3 million followers on my Facebook page that we call, the health communication by Dr. Viv. So if you can read Thai, you can follow my page as well. And I also appear in the television program to provide information and also, educating our Thai fellow how to protect and prevent themselves from the COVID-19 infection. And of course, for thalassemia patients, we have a special issue that are just published just a few months ago since the beginning of the pandemic to provide information to our thalassemia patients, how they can deal themselves, how can they manage. And a lot of our practice has been adopted throughout the country. We have our group of the hematologist expert interested on thalassemia. The good news about my country is that so far we don't have even one patient reported to have infection with the COVID-19, which is a very good news. We have a very special case which has been reported already from the Ramatipati Hospital that the patient undergone the bone marrow transplantation and have been receiving the chemotherapy for the preconditioning regimen just as the blinks of the outbreak of the COVID-19. So they have no choice but to keep the bone marrow from the donor, which is the sibling of the patient. Unfortunately, that sibling has been following subsequently detected with the COVID-19 infection. And this happened in April this year. But very fortunate for the patient, they have been not infected by the bone marrow itself, and also the sibling who have been infected has no complication or serious disease itself. So that's the condition of the COVID-19 infection and thalassemia in Thailand so far. And finally, because I don't travel, which is normally I do all the time. So when I have more time to stay at home, I just thought, what what else that I can do to help regarding the COVID-19 spreading. The other very important, and this is a sneak peek of our research that we did during the COVID infection, because I mentioned to you that I have the RT-PCR for the detecting the virus itself. So we start to try testing for all the disinfectant in order to find those that can be safe and can be used for people to disinfectant to the body and so on. So we discover one of the chemical which can we normally use in pool and the spa industry, which is a potassium peroxide monosulfate, and we testing the effect, the evaluation and efficacy of this compound as the disinfectant for SARS-CoV-2, comparing to the sodium hypochlorite, which we know as the recommended disinfectant by WHO. However, the sodium hypochlorite has a irritating effect if you contact through the skin. However, this compound is because we use in the pool and the spa, so when we contact through our skin, we should have any problem. So as you can see on the slide, we can reduce the magnitude of the ORS and the M genes of the SARS-CoV in a dose-dependent manner and the exposure time. So now I'm going to discuss regarding some of the questions that I'm going to deal with this lecture related to the COVID-19 and thalassemia. So I've been asked by my patient, my fellow physician, whether our patient with thalassemia are more susceptible to the disease itself. Does the splenectomy confer to higher risk? Should any changes in transfusion schedule or threshold be made in the context of the COVID-19 pandemic? Should thalassemia patients continue the iron chelation if they exposed or to have a confirmed COVID-19 disease? What about the treatment with the recent approved disease-modifying drugs such as the luspatercept? And what are the recommendations for the transplantation and gene therapy during this pandemic? And this is all the issue that I'm going to deal with you at the second half of my lecture. As I mentioned to you, we don't have patients with thalassemia with the COVID-19 in Thailand. We have only one case, which have been, related because of the transplantation. So most of the answer that I'm going to discuss with you is based on my search and the literature review and discussion with my colleagues, my friends, especially Professor Kipellini, Professor Ali Taher, and also Professor John Porter. And all of this country, Italy, is the center of the pandemic in Europe. In UK, they also have so many patients, and of course, in Lebanon also, being affected a lot. Let alone the recent disaster that happened to them. So there are only few, even there's over 1,000 of the publication now related to the COVID-19, but only few are related and linked to thalassemia directly. And only 3 primary original data that have been published. Several case reports have been identified. So what I'm going to discuss with you is just based on these evidence-based medicine that are available at present. So the first report related to the SARS-CoV-2 infection in beta thalassemia came from Italy. And this is a multi-center of the Center of Italian Hemoglobinopathy Network that has estimated that they have over 5,000 transfusion-dependent thalassemia and around 2,000 NTDT. In their record, they reported 11 patients with beta thalassemia who has been infected with the SARS-CoV-2 infection. 10 of them are TDT and only 1 are NTDT. So most of the patients received Deferrasirop, followed by Deferriprone, a combination of Deferrasirop and Deferral, and only one patient had not been receiving inoculation. The patient usually have the comorbidities. Eight patients from 11 have been splenectomized, and of course, they have several underlying comorbidities such as cardiomyopathies, the diabetes, chronic hepatomegaly, and respiratory disease. And when they have been infected with the SARS-CoV-2, they also presented similar to the normal individual with fever, cough, anosmia, which is very important, fatigue, diarrhea, sore throat, and difficult breathing. And 5 out of 11 patients have not been hospitalized. The rest, they have been hospitalized, and one patient require a intensive care treatment in the ICU. And the patient received different kind of the specific treatment, oxygen therapy, hydroxychloroquine, with other medication. One patient had been admitted for the high fever and bone marrow hypoplasia, lymphopenia, and granulocytosis, and this patient had been treated with the Deferriprone before. Only 3 patients received specific treatment for the COVID-19, which is the hydroxychloroquine plus ritonavir or darunavir, or the hydroxychloroquine with the anakinra. Neither of the patients died or have the severe SARS-CoV infection, or even the sign of the cytokine storm that I mentioned earlier in all of these 11 patients. So, so in their conclusion, in the author from this study concluded that from their preliminary data does not indicate the increased severity of the SARS-CoV-2 or COVID-19 in thalassemia syndrome. The following report of the infection came from Iran, which is also the epicenter of the COVID-19 pandemic in the Middle East. So this is the study from Karimi, Dr. Karimi, my good friends from Tehran, that they have reported the prevalence and mortality of the beta thalassemia in their country. So in this study, they have 15 confirmed cases of the COVID-19 infection in beta thalassemia patients, and 8 patients with suspected but not have been confirmed by the RT-PCR yet. The average age of the patient is around 36 in the confirmed cases and 39 in the suspected cases. Majority of the patients are transfusion-dependent thalassemia, and the percentage is 80 to 20 and 75 to 25. 80% of the patients have been splenectomized. They have a very kind of good control of the chelation. They have around 1,700 of the serum ferritin. The baseline hemoglobin around 9, and normal hemoglobin, the white blood count, and the platelet at the baseline. So 17 patients who have been infected from this combination of these 2 groups has mild to moderate symptoms. So over 70% of the patients are not that severe, and they are fully recovered. Unfortunately, in the Iran report, they have 6 patients died from the SARS-CoV-2 infection, and in this percentage is around 26.1%. 2 patients are TDT and 4 are the NTDT. And more than 60% of all patients who have been infected has at least one comorbidity. So when you compare in the patient who has recovered and the patient who has died because of the COVID-19 from this study, and they try to look at the other several demographic parameters such as age, sex, type of thalassemia, splenectomy, the baseline hemoglobin level, the serum ferritin, the white count, the platelet, the history of using hydroxyurea, the evidence of the iron overload in the heart and the liver and so on, they don't see any significant difference between those who recover and those who has passed away. Only the number of the comorbidity seem to be very significant. Those who has died has more major comorbidity, especially heart disease, diabetes, pulmonary hypertension, and hypertension. So these factors seem to be a very important risk predicting factor for thalassemia patients. So based on this Iranian experience, I think this is something that we should well aware of and keep our eye very closely firm to those patients who have these comorbidities. And very interesting comment from the author say that due to a relative low number of thalassemia patients with the COVID-19, comparing to the general population, and most of them develop mild to moderate diseases, even they have several complications. So they're suggesting that there may be some protection due to the hemoglobinopathies, and there's some hypothesis that the virus itself can combine with the hemoglobin molecule. However, this has not been proven yet, and there is no association study to show with a very strong enough evidence to show that the thalassemia cell can protecting infection to the SARS-CoV-2 infection. So at present, I still not really believe that it can protect. My hypothesis related to thalassemia is that our patients are very well aware of the health hygiene. They usually wearing masks when they come to the clinic, when they have some flu or common cold. They usually keep their hygiene very good, in a very good level. Wash their hair because they have to use the bathroom. They handle injection by themselves. So I think all of these good habits and good manner seem to be very important and might be a protecting factor for them from the COVID infection. However, one of the very important message that we can learn from this study is that the multiple comorbidity can predispose this patient to have a severe disease and significant higher risk of the mortality compared to the general population. So the last cohort came from a multi-center study from ICETA, which stands for the International Network of Clinicians for Endocrinopathies in Thalassemia and Adolescent Medicine. And this network is led by Professor Vincenzo de Sanctis from Greece. One of the criticism of this study is that this is just only a survey to the questionnaire to that network, and the correctness of the data may be problematic in a way. But of course, we can learn something from this study. They have 13 confirmed cases reported, 7 with thalassemia major, 3 with thal intermediate or MTDT, and 3 patients with the sickle cell disease, and this reported from 6 countries, including Azerbaijan, Cyprus, Iran, Italy, Turkey, and Oman. So when you look at these characteristics of patients with thalassemia who have confirmed with the COVID-19 infection, as you can see, there is no difference from the other two reports that I described before. Majority of the patients are thalassemia major who have been infected. The average age group is around 30-something, and it seems that the female from first study and this study, the female also more higher proportion compared to male. So the overall mean age of the patient is around 30, ranging from 13 to 60, 66, and 70% of the patients were female. For thalassemia syndrome, 6 patients has pneumonia, and 4 require oxygen therapy. And of course, the clinical severity of the COVID infection was moderate in 6 patients and severe in 3 patients. Around 70% of the patients with symptomatic require hospitalization, which is similar to the Italian study. And 1 patient died, and this is a 30-year-old female who developed the severe infection followed by death. So the author conclude that the presence of the associated comorbidity can aggravate the severity of the COVID-19 infection. So there's several groups that propose the recommendation for the COVID-19 infection and thalassemia. For example, this is published in May this year by Thalassemia International Federation, published in European Journal of Hematology, and also the National Hemoglobinopathies Panel by the UK team led by my friends Noemi Roy. And of course, there's the recommendation by the US Red Cross. So I use all of this recommendation and based on the evidence-based medicine to back and answer all the questions that I posed before. So are the patients are more susceptible? And the answer to the serious disease, the answer is yes, if they have multiple comorbidities. However, it doesn't seem that, having thalassemia have them more at risk of infection. They have more risk of serious disease, yes. Does the splenectomy confer a higher risk of COVID infection? Splenectomy is not known to increase risk for viral infection. Bacterial, yes, but there is no specific data exist for the COVID infection. And as you can see, there is no comparative study between those thalassemia patients who infected and not infected. And because we cannot do such a study in Thailand. Splenectomized patients who develop fever, they should be evaluated for bacterial infection first and receive antibiotic to recover the secondary bacterial infection. But of course, during this COVID infection, we have to screen for the nasal swab and perform the RT-PCR as well. How about the transfusion schedule? Should we change the schedule? Should we, increase the threshold for the patient during the COVID-19? The answer is no. There is no evidence to support that the virus can transmit through the blood transfusion. So, and all the TDT patients should be more beneficial to maintain the hemoglobin level. And, I can confirm this statement because, during the lockdown of Thailand, we have to reschedule our patient and they have to receive less transfusion, not because we're afraid of them to getting infection through transfusion, but because, some of them has a problem related to the logistic to travel from the other province to come to Bangkok to get blood transfusion. And that result in several cases who has become being affected with bigger spleen and hypersplenism. So I would say 30% of my patients who are transfusion-dependent thalassemia, after we reschedule or reduce, increase the threshold, usually we provide blood transfusion in order to keep hemoglobin around 10 pre-transfusion hemoglobin, and we reduce to around 8 to 9, and resulting in several, up to 30% of cases has a progressive splenomegaly. Unfortunately, one case has a bigger spleen and we cannot reduce it after we release the lockdown, and they probably have to undergo the splenectomy eventually because of the condition of the hypersplenism. So if you don't have any issue related to the lockdown, you should not reduce the transfusion visit to the patient. And also, we probably have to maintain the high level of the safety measure for the donation and transfusion clinic. And this is what we are doing very well in Thailand and also in Malaysia. We have to provide a frequent disinfectant. That's why I did the study on what disinfectant that we should use. We do the temperature screening, we do physical distancing, and ask our patient to wearing masks all the time when they are in the clinic, or even when they see me. And when I provide my medical service to them, All of our medical staff have to wear masks all the time when they are in the hospital and also in the clinic. Should the patient with thalassemia continue iron chelation if they exposed or they have the confirmed COVID disease? At present, there is no data available regarding the iron chelation therapy. We have no information to say that our iron chelation can affect any susceptibility to the disease itself or the severity of the infection. If the patient exposed to the COVID-19 but asymptomatic, there is no reason to interrupt the iron chelation. However, in our experience, if the patient receives the deferriprone and has the infection, we will ask the patient to stop the chelation with the deferriprone, because one of the major side effects of the deferriprone is the leukopenia. And we know that in patients with the COVID-19 infection, they can also have leukopenia as well. So we don't want this clinical effect to mask the infection of the COVID-19. And if the patient becomes symptomatic, particularly the moderate to severe disease, and they require hospitalization, we can interrupt the iron chelation. However, the ICU physician has to work with us as a hematologist in order to help, because sometimes the patient might have the comorbidities such as the cardiomyopathies due to the cardiac iron overload. So we have to help the ICU intensivists and help them if the patient requires a continuous intravenous chelation therapy with desferon. And the other aspect that because many comorbidities of thalassemia are related to the iron overload, so the patient should be reminded that they should adhere to the iron chelating dose and the schedule as they recommended by us, because we want to reduce the possible organ injuries and the future complications. So all of my patients, they receive the same iron chelation regimen, and they have been confirmed and advised not to stop chelation, because we don't have evidence that the chelation will increase their risk. On the opposite way, if they don't do the chelation properly, they can have comorbidity, and that can be very harmful to them. How about the other disease-modifying drugs, such as the luspatercept? At present, again, there is no data available regarding the luspatercept and the COVID-19. And if the patient are currently taking luspatercept and they having a benefit from the drug itself, for example, if we can reduce blood transfusion, this is based on New England Journal of Medicine publication this year, there is no reason to stop the treatment. And actually, in our experience that we use luspatercept in over 65 patients in my center, I have found, because of the policy of our country during the lockdown, our IRB want to reduce the hospital visit of the patient. So I have to postpone the patient from coming to receive the luspatercept. And some of them who stay outside Bangkok had to stop the drug itself. And that seemed to have a more, the opposite adverse effect to them. Some of the patients have become a bigger spleen. And of course, they require more blood transfusion. And some of them have become derailed and cannot get to the status during their receive the luspatercept. So based on my experience, I would say wholeheartedly supporting this statement that they have no reason to stop the treatment if they benefit, especially if we can reduce transfusion frequency using the luspatercept. We can reduce the amount of transfusion required. We can save the stock of the blood transfusion, which seem to be shortage in many countries. And finally, what are the recommendations for the stem cell transplantation and gene therapy during this COVID pandemic? And the answer from all of these guidelines, including experience from Thailand that I mentioned before, the answer is no. During this high risk of this COVID infection. We don't want the patient to come to the hospital. We don't want to take the space in the ICU. Or some of the transplant centers and transplant facilities can be modified to accept the serious COVID-19 infection. So there's several risks related to the myeloablation. So most of these allogenic stem cell transplantation and gene therapy must be postponed during the initial phase of the pandemic. So I'm very sorry to all my colleagues who are transplanters. You're out of your job for a while, unfortunately. And there is no evidence that the SARS-CoV-2 can transmit it through the hematopoietic stem cell graft, as I mentioned earlier about a case from Thailand. So in the UK team, they, suggesting some of triage when you have patients with hemoglobinopathies presenting with the clinical symptoms suggesting fever, cough, myalgia, are suspected to have the COVID-19 infection. In that scheme, they divide the patient after evaluation into, admission or not admission, and, or have a recommendation. However, I don't think that, this kind of recommendation will be really applicable for us because, we have to rely based on our locality and the local policy. For example, the local policy in Thailand, when you have people who have suspected with the COVID-19 infection, even they have the mild disease, we admit everybody. We don't want them to stay at home. So, most of these cases will be observed because, especially for thalassemia patients, they can be, getting worse in a blink of hours. So it's much better to have them monitored. But I don't think that, facility in country like UK can cope with such a huge number of these spreading. So finally, this is my summary. Thalassemia patients do not increase risk of the COVID-19 infection compared to the general population, or at least we have no evidence. But protecting or not, I cannot say. There is no direct scientific evidence to show that. There's several hypotheses around that, they might be, less susceptible to the infection itself. The more comorbidities that the patient have can result in increased risk of mortality. And this is very, very strong based on the data from Iran and the data that from the multi-center study published by Professor DeSantis. So several morbidities, increased mortality. There is no evidence that the COVID-19 transmission through the blood transfusion. So we need to continue the transfusion schedule, no change for the transfusion threshold. Provide your patient with the best that you can. You have to withhold stem cell transplantation or gene therapy until the COVID-19 stops. And there is several reasons for that. And finally, for all my Malaysian friends, I think, as I showed earlier, you are ranking, as one of the best in the world related to the COVID-19 recovery scoring. So what you are doing is one of the best. You are one of the best in the world. So such as your triage, your guideline, how do you manage the PUI, patient under investigation. So your plan to hospitalize the patient, either thalassemia or not thalassemia. So I think, you should provide the best practice. You are one of the best practice in the world. So, and finally, is the final word to all of my friends who are on the, in Malaysia and, watching through this webcast. Stay healthy and stay safe. As the healthcare practitioner, we are the most, has the most risk to get the COVID-19 infection. So I hope you're not getting it. And please stay healthy, stay safe to be for our patient. Thank you very much. Thank you. I cannot hear.
Hello.
So I can have question and answer.
Thank you. Thank you, Prof. We have one coronavirus through infected blood. So all the doctors need to have screening before donation. I think Prof. already addressed these questions. Unless Prof. want to add any other info on these questions? Prof.
Yes, sure. You can hear me well, right?
Yes, yes.
Yes. So as I mentioned earlier, that there is, I mean, as I showed earlier in the slide regarding the viral dynamic. So there are only few window of the viremia, of the coronavirus viremia is around, around day 5 to day 7 that we can detect the virus through the blood, okay? Which is very similar to the other coronavirus infection. However, the amount of the viremia is very, very low. So there's a previous several studies from China and also the study from the Middle East, especially when they deal with MERS, which is also another coronavirus infection, and also the SARS virus. So because of the very short period of the viremia and the very low amount of the virus in the blood, so there is no evidence that we can contract this COVID-19 through the blood transfusion. In Thailand, we use a questionnaire to screen for the blood donor. So we don't testing the RT-PCR before the donation. So we use a questionnaire related to the past medical history, the history of contracting with the infected individual, the history of going into a community space which have increased the risk. So by using this questionnaire, I think that should be sufficient enough to provide a screening for the donor. So far, we don't have any report of the blood donor infected with the COVID-19. So I think I answered the first and the second question. And the third question is regard to the XGate FCT. Does splitting the dose to twice daily work as well as the daily dosing in terms of the efficacy? This is nothing to do with the COVID-19. Actually, I reported the splitting dose of the defracyral back in 2015, many years ago. Based on our experience, the recommendation of the defracyral by the Novartis is the once daily dosing. And around 80% of the patients seem to work very well with this recommended regimen. So we don't need to do the dose splitting for the defracyral unless the patient seem to have a non-responder or lower response compared to the rest. In our experience, it's around 20 to 25% of the patients require the dose splitting. But we have our criteria to use the dose splitting, including the patient need to receive defracyral over 35 mg per kg at least 6 months without any trend of reducing the serum ferritin or maintaining the liver iron concentration and the cardiac T2 star based on MRI. So I hope I answered the question.
I asked one question from we receive from our experience, we see from the reported.
I cannot hear you properly. Can you repeat that, please?
see from the reported cases that you right now, there's no.
Sorry, Dr. Zul, we are having difficulty hearing you.
Cannot.
I cannot hear. Oh, it's the number 4 coming up.
Maybe you can answer the number 4 first.
Yes. What were the strategy to increase blood donation during the COVID pandemic? Yes, I think that's a very important question. You know, I have done several things in Thailand, you know, including, you know, the increase the knowledge approach that I mentioned to you. I went on the several national television program in order to encourage people for blood donation, and also, you know, educate them that, you know, we have a very safe environment at the donation unit, donation center. So they would not catch the COVID-19 because they had to go to the hospital. I think that's very important to encourage the people. And of course, I use several social media, including the page that's followed by, you know, 2 million people to educate, you know, people that, you know, they need to go to the hospital to provide a blood donation. So I think, you know, you have to use several measures in order to at least maintaining the number of the donation. I don't know with maybe you're probably doing that as well, but, you know, I hope that what we done might be applied for Malaysia as well. Right. So can I know your thalassemia algorithm management related to medication? Extate, deferral, deferriprone. So at present, we use chelation based on our reimbursement system. Because the chelation is fully supported by the government. And also helping them to write the guideline. So we start with Extate. Defracyroc is the first line for our pediatric patient. So everybody will receive defracyroc first, okay? And if they have, you know, side effect of defracyroc, they can use Desferal for injection, which is a very unusual case. After 6 years of age, you know, we try to switch to deferriprone because we make the deferriprone by our government facilities, so it's much cheaper. So some of the patients will switch to the deferriprone if they respond well to the deferriprone, if they don't have any side effect to the deferriprone, especially the arthralgia and neutropenia, they can continue with the deferriprone. And but if they have the side effect of the deferriprone, they can switch back to the defracyroc. Okay, so this is the our approach now, which is based on the reimbursement system. So the question number 7: does a TDT patient have protective effect against the COVID infection after receiving blood products from the donor who recovered from the COVID-19 infection? So this is a very, very interesting question theoretically. Unfortunately, there is no data to show that. And the other thing is, because as we all know, related to the reinfection, which have been recently reported from US, from Europe, that, you know, people after infection with the first strain of the SARS-CoV-2, after 4 months, they infected with the second strain, and that provide us with some evidence that, you know, this antibody probably cannot last so long. So the amount of the circulating IgG that they're receiving might decline, you know, with time. So I don't think that they will receive much protection through the blood transfusion. That's my hypothesis, because there is no direct scientific evidence to support this. Yep.
Okay, thank you, Profit. I have one last question with regard to COVID-19 in pediatric. If we
Yes.
see from your report and from our experience, luckily pediatric growth is not really a problem.
That's
Is
right.
there any biological, immunological explanations why this COVID-19 is
Yes.
not attacking our population, pediatric populations?
That's right. Thank you very much. That's a very important question for us as a pediatrician. Actually, one of the article that I wrote in the bulletin for my thalassemia patient, and also on my social media on my page, which have been shared over 10 million share in Thailand, is related to the pediatric infection. It's very important because at the beginning of the COVID spreading, as I mentioned, we don't have much information. We don't have much knowledge. And, of course, children are the most vulnerable population that can get more serious infection. It's very fortunate that based on the experience in China and also subsequent publication in the pediatrics, as you may aware of, it shows very clear that up to 20 to 30% of pediatric population can have become asymptomatic infection or asymptomatic carrier. And there's several hypotheses that this children population may have the other coronavirus infection, from cold, common cold, which can have some protection and modify them. The other thing may be, related to the comorbidities that they don't have. They don't have hypertension, they don't have diabetes, and so on and so forth. Okay. However, there's a very selected group of pediatric patients that I would think they may have the genetic risk, similar to those who have the Kawasaki disease, because there is several reports of the Kawasaki-like illness in pediatric population who infected with COVID-19. However, I think this is a very selected group, and they must have some of the genetic predisposition, but not for the general pediatric population.
Thank you. I think with that we wrap up. We shall go to next speaker. So we are glad to have Dr. Loh Pei-Ling with us. Dr. Loh Pei-Ling graduated from Malacca Medical College in 2010, and during her student days, she was awarded with Dean Honor Roll in 2009. Eventually, Dr. Loh pursued MRCP and graduated with MRCP, Royal College of Physicians London in 2017. So at the moment, Dr. Loh is working in Penang Hospital, Malaysia, and she's doing the trainee in hematology or fellowship in hematology. So Dr. Loh, we share the presentation with us, and I'll pass this to Dr. Loh.
Thank you for the introduction, Dr. Juliha. Good morning to everyone. I'm Dr. Loh I'm a hepato specialist from Penang General Hospital. Today, I would like to share a case with a patient is under our center follow-up. At this moment, I feel very lucky and fortunate to say that so far, none of our thalassemia patient under our follow-up have been infected by COVID-19. So I would like to start presenting a case. This is Mr. FJ. Is currently a 23 years old man who is diagnosed to have thalassemia major at 2 years old with a genotype of IVS1 and CD41-42, who was required of monthly blood transfusion and was started chelation therapy since 6 years old. and he was referred from our pediatric colleagues at the age of 21 years. For the past sedation history, Mr. H started on a subcutaneous desferrigine, the desferal, since 6 years old, and was added on oral deferriprone L1 at 10 years old. However, due to multiple episodes of neutropenia, deferriprone was discontinued after 1 year. Later on, patient was only on subcut desferal, desferrigine DFO monotherapy from 11 years to 16 years old. During that period, patient was staying in the boarding school, staying and studying in the boarding school, probably being away from the parents without a supervision, supervised from the parents. Patient was very poor compliance to the injection. Hence, he was shifted to eject in a DT form from 16 to 19 years old. However, the compliance is still very poor. And so on top of the eject DT form, soon he was added on, started back the subcut DFO from 20 to 21 years old. Will be the table showing the serial investigation chart since 2013 to 2018, when the patient is still under pediatric follow-up. As you can see, the serum ferritin trend from 2013 to 2018, the ferritin level was started with 2,133, was increased every year, and up to 2018, the serum ferritin level is go up to 9,135 microgram per liter. And as well from the MRI T2 star, the cardiac iron load also increased by every year. It was quite normal from the initial 2013 to 2017. However, in view of increasing the ferritin level, they show some mild cardiac iron load in 2018. And as well for the liver iron load, in 2013, there is some moderate iron load in the liver, and also increased year by year. In 2017, in the MRI T2 star, there is a severe iron load in the liver. However, in 2018, from the MRI T2 star report, there is only mild liver iron load, which is not really tally with the trend, and also not very tally with the serum ferritin level. This we were clearly possible there is some error in the reporting, and we did approach a radiologist for further reporting. And the last column will be the summary of the chelation therapy being adjusted according to the ferritin level. This patient was first visited to our adult hematology clinic in April 2018. During that time, patient was 21 years old. When he first came to us, he was asymptomatic with no any endocrine abnormality. The first ferritin level at our clinic received was 9,135 microgram per liter, and the MRI T2 star showed there is mild cardiac iron loading, and with mild liver iron loading, which is we clearly probably there is some error in the reporting. Otherwise, the echo, renal profile, and liver function tests are all normal. Looking at the very bad compliance issue with this patient in the past, we actually able to enroll the patient on the CART program, and patient was started on eject in the FCT form on January 2019. Patient was started with 1,080 mg per day, which is around 20 mg per kg per day, in order to improve the compliance. And we also combined with subcutaneous desferal 2 grams 5 times per week, which will be roughly 40 mg per kg per day. We will be thinking the compliance issues likely to be contributed by multiple psychosocial issues. During that time when we saw the patient was just newly married and also unemployed. And during our follow-up, we also found that sometimes the patient couldn't come to our clinic due to some financial issue and also some transport issues. Hence, the compliance to that is quite poor. And other than the compliance issue, patient also have some injection, some side effect from the infusion, as a patient couldn't tolerate the higher dose of the infusion. He turned to develop some reaction and also infection, also injection site. Hence, we actually very difficult to further optimize the infusion to higher dose. In May 2019, the serum ferritin is further increased to 11,566 microgram per liter. Hence, we counseled the patient, and the patient was warded for continuous IV DFO infusion. Patient was started on IV Thalassemia infusion 2.5 gram continuously for 24 hours, and also patient was will increase the exit FCT to 1,440 mg OD, which is around 27 mg per kg per day, which is almost close to the target cardiac dose. During the on the day 3 of DFO infusion, patient had a very high spike of fever, more than 40 degrees Celsius. Immediately, both DFO and the exit FCT were withheld, and patient was started on antibiotic. We have started patient on thalassemia and also amikacin. On the day 2 of fever, we received from lab, there's a verbal report, blood culture will grew gram-positive cocci. Hence, we added on the vancomycin, 1 gram step with 750 BD. And subsequently, once we got the formal report with the blood culture group MSSA, we was off all those antibiotic and switched to the target antibiotic, which was IV cloxacillin for the next 2 weeks. In total, we are only given 1 dose of amikacin and 2 doses of vancomycin. On the day 6 of admission, we noted the patient developed non-auricular acute kidney injury. The creatinine was increased from baseline, which was around 62 to 94 and 1000 and go up to 500. The creatinine was increased around 8-fold within 4 days. And on the day 8 of admission, in spite of adequate hydration, patient required dialysis due to worsening of kidney injury. At this moment, we think acute kidney injury probably likely secondary to the sepsis or maybe drug-induced, as we are started patient on IV amikacin and also vancomycin, and possible the acute kidney injury will be secondary to EGET because we were started patient on high dose of EGET during that time. During this admission, patient was required 2 hemodialysis. And subsequently, the creatinine able to come down and recover slowly without any hemodialysis. Once the kidney slowly recovering, we will start back the patient on subcutaneous DFO on the day 11 of admission with a lower dose, 1.5 gram over 12 hours. On the day 15 of admission, we also increased the infusion from 12 hours to 24 hours. And the creatinine is further recovering and reducing. Once the creatinine clearance improved to more than 30 ml per minute, subcut DFO was switched to IV for 2 grams for 24 hours. For this admission, patient was total received 14 days of DFO infusions, as patient was keen to go home and not want to further stay in hospital, so we were discharged after given 14 days of infusion. When discharged, creatinine was improving and also reducing in trend. However, the creatinine was still not yet touched the baseline, which was 62. Hence, the patient was discharged with subcut DFO 2 grams over 24 hours, which is around 40 mg per kg per day. Subsequently, patient was continued to follow up at our daycare. Upon discharge on May 2019, the creatinine was, during the discharge, the creatinine was 158, not yet achieved the baseline. The baseline was around 62. Patient was discharged with subcutaneous DFO 2 gram over 24 hours, which is 40 mg per kg per day. And you see this patient around 1 week after discharge at our daycare, the creatinine further improved to 92. And at this point, we actually started back, in view of patient having severe iron overload, we started back this patient on very low dose of FCT, which is 720 mg OD, around 14 mg per kg per day. And the subsequent blood transfusion sections will be 3 weeks later. We see this patient during the subsequent transfusion section. The creatinine further go down to 73. However, in view of recent acute kidney injury that required dialysis, we actually maintain the same dose. We tend not to increase the dose too fast, and so we will see back the patient for another section, the transfusion section, which is around 3 weeks later. The creatinine seems to be quite, in July 2019, the creatinine seems to be quite static. Although there is also some mild transaminitis, the ALT that time around 62. We will slowly increase the FCT dose to around 17 mg per kg per day, and also combined with a subcutaneous DFO 2 gram 5 times per week. Roughly around 3 months after discharge, creatinine seems to be quite stable, and although went back to the baseline, we further increased the exact FCT to around 20 mg per kg per day. As in the MRI T2 star, we can see there is some mild cardiac iron loading, so we are aiming to achieve the cardiac dose, which is around 28 mg per kg per day. This is the iron assessment for this patient during our follow-up. As we can see in 2018, the serum ferritin level is in 2018, the serum ferritin level is 9,135, and there is mild cardiac overloading and also some error. There is a mild liver iron loading, and up to 2019, the serum ferritin level is around now 9,546, with the moderate cardiac iron loading and the severe liver iron loading. And we can realize that after we putting the patient on FCT, the compliance is pretty better, and patient is quite compliant with the medications, and the ferritin level can slowly reduce. As in the October 2019, the ferritin level is go down to 8,214, and further down in July this year, the ferritin level is also reducing to 7,500, and the compliance issue is pretty good. However, the MRI T2 star shows there is severe cardiac iron load and also severe liver iron load, which is not very correspond to the ferritin level, but we are keeping to optimize the patient on the proper dose of the EGEC, and we will plan to reassess again this patient for the MRI T2 star in another 6 months' times. For this case, we do encounter few challenges of the management. From the initial, there is a very poor compliance issues, and actually able to improve the compliance with after we started patient on FCT, the compliance is markedly improved, and also after multiple sections of counseling, and we are actually counting every valve of DFO during every visit of the transfusion sections. And The second issues of these patients will be the side effect of the chelations. Patient did develop multiple episodes of neutropenia while the patient on D-ferriprone. And also there is event of acute kidney injury while the patient on HJAK, and patient also couldn't tolerate high dose of DFO infusion. When you try to optimize the infusion dose, patient tend to develop some local infections and also reaction over the infusion site. And we also have a doubt on the managing while the patient on HJAK with a past history of acute kidney injury, how fast and how soon we should increase the dose, especially though the patient with severe iron loaded. And also, finally, during current COVID pandemic, Malaysia actually implementing RMCO, and we are also practicing some social distancing. And we are, although all the patients still on their schedule for the transfusion sections, but if you try, when we try to, we also met the difficulty when you want to monitor the patient more frequently, because they may have some difficulty to come more frequent during COVID pandemic period. This will be our challenges when try to manage this patient.
Thank you, Dr. Loh. I think we have one or two questions here, Prof. Vip. Can we show the questions? Or maybe I just read up from the...
Can you hear me?
Yeah.
Yeah, I can hear.
So I just want to make my comment related to this very interesting case. And thank you very much for your fantastic presentation. And thank you very much for sharing this interesting patient to all of us. So I think we can learn an awful lot from this case. It's a very, very important to address that this case is a very good example on how poor drug compliance can affect, a long-term morbidities related to the iron overload. Because as you beautifully described the past history of this patient who are not really comply with the chelation therapy. And that, leading to long-term complication and, several complicated situations that occur during the recent events of the intravenous IV destro. One of the important points that I would like to address, which is, I think is very important for all of us, because, the beginning of this, the arrangement of the patient occur during the elective intravenous destro treatment. And it seemed to me that, this MSSA infection has been introduced into the patient. So during the bacteremia, we shall stop all the chelation therapy because, the iron chelator, when it's grabbed the iron molecule itself, it can work as the iron siderophore that donate the iron molecule to bacteria, and the bacteria can use this iron to enforce their growth. So normally we shall stop the chelation treatment for all the chelator because the Ka of this iron binding with the iron chelator itself is not as strong as the force from the bacteria to grab the iron out. So we shall withhold all the chelator until we have a clean, hemoculture negative, and we stop all the chelation therapy, all the antibiotic therapy for the patient. So this is a very important point that I would make. The second point, also very important, and you already mentioned, is the validation of the MRI, because one MRI measurement in 2018 seemed to disproportionate to the serum ferritin and the presence of the cardiac iron by using the T2 star. So I think that's a very important point, and I totally agree with you on that. That the measurement of the liver iron concentration at that point doesn't seem to be correct. And I think as a hematologist, we have to believe, as we see for the whole patient, you see the trend of the serum ferritin, which is not reducing, but on the opposite, it keeps rising. And the T2 star is worsening. But how can you have a better LIC? So this is just an urge for us as a hematologist to back and talk to the radiologists about how they do the calculation and validation for the liver MRI. And I think that's a very important point. And I think everybody can learn from that. Back to this patient. Now you have patients who have renal compromise after acute renal injuries. It would be very difficult for us as a hematologist to predict whether how rapid this can recover. Based on the history, because this is an acute injury due to the infection, and maybe the patient might have some kind of the septic shock, or a very serious infection. So after you clear and they are still young, so the kidney function, can improve. But throughout this period, I would rather try to keep the doses of the defracyral, which is we know that it can increase the baseline creatinine level up to 33% compared to the baseline at a lower range, because this is a dose-dependent adverse event of the defracyral. So the dose that you provide with the FCT around 20 mg per kg, which is equivalent to around 30 of the original defracyral, I would go with that dose and keep it at that dose as well. One of the modification I would suggest, because based on the previous history in 2016 up to 2018, that even the patient received defracyral up to 38 mg per kg, and it didn't seem to have a decline of the serum ferritin. So I would suggest to splitting the dose. Of course, Kosi told me not to say something off label. Okay, you can off record now, but I would suggest to splitting the dose of defracyral. And I would get that this may be one of the non-responding patients, and that one thing. The second thing is because you mentioned about neutropenia. Actually, the neutropenia due to the deferriprone is not absolute contraindication of using deferriprone. The only absolute contraindication is agranulocytosis. So if you have neutropenia, and you can re-challenge the patient with the deferriprone and keep close monitoring for the absolute neutrophil count. So the neutropenia is not the absolute contraindication. So in this case, I would rather say the patient still benefit for receiving, rather small dose of the deferriprone as a combination. You can start with like 50 mg per kg and monitor the neutrophil count closely, and you can adjust so the patient can still benefit from the deferriprone. I have many patients like this, okay, because when they have complicated patient with chelation, they usually send them to me. So this patient may require, the dose of desferal in combination of the defracyrob and also the deferriprone. And more recently, I have even more complicated patient than this, a granulocytosis due to deferriprone, a patient who have the Fanconi syndrome in combination with the defracyrob, and that is all the contraindication, and also have the very serious local reaction to desferal. So in those cases, I start to use the other kind of off-label. Okay, you can off-record now. If you go to the literature, there's the use of the calcium channel blocker, amlodipine, especially those who have cardiac iron overload. There's a paper in Blood back in 2016, so you can find that. And also the use of some of the acid secreting blocker, especially omeprazole. So there's several evidence to show that the use of these off-label combination can help to tailor your chelation therapy. So this is just sharing our experience. Okay.
Right, Prof. Vip, we have a few questions here.
Yes, sure.
I think the first questions, I think you already addressed that.
Yes, that's right.
Yeah,
that's right. I think that's a very obvious the discrepancy.
Yeah.
So you need to go back and reevaluate the process of MRI. Yes, because sometimes they may change the instrument, they may change the scanner. We have a very good relationship with cardiologists and radiologists. So we work as a team, and we have a regular meeting every 2 months to discuss about cases. And this is very important because when these radiologists, they perform the scan, they don't know the patient. They don't know the clinical presentation. So in our clinic, in our hospital, we have the regular meeting with them every 2 months, and we discuss cases to see whether, I told them, this case is not quite right. Can you repeat that, or can you reanalyze your results? So I think that's very important.
So it's important.
I know your practice for maximum dose of X-date, desferal deferriprone. So X-date, the maximum is 40 mg per kg, just for the conventional one. And if you use the FCT, it's 28 for the X-date FCT. I don't do over 40. For the desferal, the maximum dose is 60 mg per kg. But when you use 60, you have to be aware of possible risk of increased local reaction. So in some patients, I combine with some of the corticosteroid application before and after injection. For the deferriprone, you cannot use it over 100 mg per kg because there's a report of the neurological side effect if you use it over 100. So the maximum is 100 for deferriprone. So the question is, during recent acute renal failure, what is the optimal treatment of heavily iron overload patient? As I mentioned earlier that, in this case, because of maybe acute kidney injury related to the sepsis and the septic shock. So you have to treat this condition first. And because the patient did not seem to have cardiac compromise due to cardiac iron overload, ejection fraction remain within the normal range. Even the T2 star is showing a moderate iron overload in the heart. But the patient did not have the cardiac arrhythmia, and the ejection fraction remained within the normal range. So during the acute renal injury, acute renal failure, if it is me, I would rather not use IV desferal at that moment. I will wait until the patient fully recover from infection and start, chelation one by one. And in this case, I will start with desferal subcutaneous instead of using the IV. Because I understand that you use IV in order to as the elective cases, right? Elective treatment for the patient. So for the last question, can you explain the iron and cardiac iron overload complication?
There's no.
I don't understand the question.
There's no complications. Yeah. Let's do question 12, Prof.
So because the liver enzyme is not increased yet, right? If I understand. So there is no evidence of the transaminitis in the patient. So as the patient received 1 dose of amikacin and 2 doses of vancomycin, you think that the extent is the main culprit of acute renal failure? I don't think so for the question 12, because it's obvious that the patient have MSSA, the patient has sepsis, right? And it's possible the patient may have the septic shock and compromised by the serious infection and so on. So I think, and of course, this is a multifactorial. Is maybe some related to the antibiotics, maybe some related to the extent. But I would not point my finger to the extent for this.
Prof. Vip, to that question number 12, can I add in, because subsequently when they use extent without any infections, there's no problem with renal functions.
That's
right.
So
I don't think extent is a culprit here. I
think so. I agree. Yes. May I know your address? What is the threshold for elevated liver enzyme to withhold extent? Yes. Normally, we will withhold when it's increased 3 times over the baseline. So if it go over 3 times over the baseline, I will withhold. But of course, we would re-challenge. Even it's over 5 times. Because sometimes, in thalassemia patients, they have intercurrent infection. They, sometimes we cannot blame the iron chelation for the transaminitis because they may have some, asymptomatic viral infection, which we don't know. And we are in the world full of viruses. So, the patient would be benefit from the chelation. So I would re-challenge. Even it's increased up to the 5 times. So the last question relating to this patient, what started?
This addressed to Dr. Loh probably.
Sorry?
This addressed to Dr. Loh, number 14. Maybe Dr. Loh would like to answer the question.
This is not my question, I'm sorry.
Let's Dr. Loh answer the question.
I cannot answer this. Yes.
I think related to the question 14, because a patient was at the hospital around more than 3 days. So we actually also want to cover from hospital-acquired infection. Hence, we started on vancomycin.
On that question as well, Dr. Loh, did you do the vancomycin or amikacin level to see they are on the toxic level or not?
Yeah, because we only given 1 dose of amikacin and also 2 doses of vancomycin. So we actually off immediately after we got back the formal report. So for this case, we actually not doing the TDM level.
I think that's the last questions, and I think we shall conclude our webinar sessions today, and we should agree that we have very good lectures by Prof. Vip and very interesting case by Dr. Loh, and we have very good and interactive discussions. And I would like to thank Prof. Vip and Dr. Loh for sharing the knowledge and experience. And we shall close this webinar session, and thank you for all the audience for all the questions as well.
Thank you very, very much.
Thank you very much.
And hope to see you all in person very soon.
Soon, yeah.
Thank you.
Bye-bye.
Thank you.
Okay, bye-bye.
Thank you. Bye-bye.
Thank you once again. We have come to an end of the webcast. Thank you for making time in joining us throughout this interesting presentation. To all participants, you will receive a cert of attendance for your participation today. Stay safe and take care.
Thank you.
Thank you.
Thank you, Prof. Thank you, Dr. Zhu. Thank you, Dr. Lau.
Thank you very much, Kosi. Thank you very much.
Thank you, really.
Bye. Thank you,
Bye.
really.
Bye.